turn it over to you. All righty. Hello, everyone. This is session IC19, Changes with Age, Justification for Custom Manual Wheelchairs for the Geriatric Client. And we will have Christy Hamstra begin the presentation. I will be your moderator. My name is Joe Stratman, and towards the end of the presentation, we will put the CEU code in the chat, and I will also mention it out loud. But without further ado, Christy, all yours.
Thank you so much. Thanks so much for joining us. And if you just put your questions in the chat, I will do my best to get to them at the end of the presentation. But let's go ahead and get started. So just who I am, my name is Christy Hamstra. I'm a physical therapist. I've been a therapist for a little over 20 years, maybe actually, I think we're going on 23, but I worked in all sorts of settings in my career. I worked about 2 years for an independent dealer in Michigan, and I currently am a clinical education specialist with Motion Composites. And I live in right outside of Detroit, Michigan. So Dearborn Heights, Michigan, if you're from Michigan. So thanks so much for joining us. And just a real quick shout out to Motion Composites, who is my supporter of this presentation. So if you're not familiar with us, we make ultra lightweight manual wheelchairs, and we're located in just outside of Montreal in Quebec, Canada. We have been in business for about 14 years and continue to win lots of awards throughout for products and innovation. So without further, let's jump right into our topic today. So we're really talking about geriatrics. And so we're going to look at musculoskeletal changes that are associated with normal aging. How can we make some distinct adjustments to kind of counteract some of these changes? And then look at some specific justifications for the geriatric client for an ultra lightweight manual wheelchair. And again, we like to start all of our presentations just kind of reviewing evidence-based practice, because I think it is important, especially for me to remind myself as a practicing clinician for over 20 years, that there is a lot of research out there and what evidence-based practice actually means. And so it's not just throwing the baby out with the bathwater, it's taking those 20 years of clinical expertise and taking the best research evidence and our patient values and preferences and really helping us to get what is going to be best for our clients. So let's kind of look at an overview of geriatric seating and mobility and what does it look like. And again, we're specifically looking today at ultra lightweight manual wheelchairs. I know that there's plenty of other wheelchairs out there and other wheelchair bases that would work for your client. I'm not saying that this is the only one. I'm just saying this is how we're going to look at it today. But some common assumptions is I think where we want to start this discussion. And, you know, depending on who it is, but maybe from a professional or from a caregiver, sometimes we might hear assumptions about a geriatric client. They only need it for a short period of time, or they're going to get better as soon as they get home. This one's my absolute least favorite. They're old. Why do they need what's best out there? Or this one, they don't need a custom wheelchair. They're ambulatory. Or they just don't qualify for an ultra lightweight manual wheelchair. So these are some of the assumptions. Maybe the client themselves, I don't need a wheelchair. Those are for old people. If I get a custom chair, I'm giving up. Isn't this lightweight chair that they gave me, this lightweight chair, isn't that the best there is? And what does it mean to even have a custom wheelchair? So I want us to just look back over here to the professional assumption. They don't need a custom wheelchair, they're ambulatory. Let's just remember that ambulatory can have many definitions. I'm a physical therapist by profession. We want everyone to walk, right? We're all about gait training. We're wanting everyone to walk, but we also want to make sure that they have quality of movement, right? So what is the definition of what does their ambulation look like? How long does it take them to ambulate this certain distance? Because just because the client ambulates with an assistive device, either for very short distances or with physical assistance, doesn't automatically disqualify them for having a custom ultra lightweight chair. So again, what is the quality of the ambulation? How much assistance do they need? How likely is it that that client is going to be independent with ambulation? If you anticipate that your client's going to need a wheelchair for a minimum of 4 to 6 hours for greater than 6 months, you probably can qualify them for that higher level chair. Again, using the changes with age that we're going to discuss throughout this session. So when I started thinking about this, and some of this building for this presentation started when I was working as a supplier, and specifically working in a seating clinic, seeing client after client come in these, these basic chairs saying, I need a chair, this doesn't work for me. And thinking about, well, why are all of these chairs going out there? And so there really is a lot of background. There's poor geriatric prescription, right? So regularly these chairs, either this type 1, if you're kind of in the Ontario market, or K1 to K3 or lightweight, is regularly provided on a rental or purchase basis. By definition, these chairs should only be used for occasional use, but they very often turn from that occasional into full-time use very quickly without much thought. They're habitually overprescribed for many reasons. It's very easy to qualify for coverage for some of these chairs. There's very limited paperwork or interaction with a seating clinic, with a seating therapist, if at all. They're often ordered by discharge planning. And so again, they don't require any skill to prescribe. One size fits no one. Sometimes therapists don't understand how to qualify a client that is possibly they're looking at that highly active, and they don't think that your client actually fits into that. So let's continue working here about this. So long-term care, again, continuing with poor geriatric prescription. Many areas in the world, they do provide some access to customization for manual wheelchairs in the long-term care. Canada is one of them. There are a few states in the United States that do, most do not. It's part of the responsibility, if you're in a nursing facility or long-term care facility, to provide what is necessary care for that resident. I personally feel this is not best practice, as many facilities only provide a basic chair for clients with complex needs. And you'll see this as we look through some of the research on geriatric prescription. So I guess it can be a positive, right? The wheelchair is funded by the long-term care. The negative is there really isn't much choice or options when it comes to what that chair looks like. They're very overprescribed, even when justification exists for a higher end, more complex chair. And this includes using reclining chairs, which are exceptionally heavy and provide zero postural support. If you've worked in long-term care in pretty much anywhere of the world, you see it quite often where geriatric clients are provided with not the best fitting equipment. So a lot of the research that's been done on geriatrics has been done in long-term care facilities, and looked at, most of them are standard wheelchairs. And so both of these women are women that I know. They are both very tiny women. And by tiny, I'm going to say 5'1", 120, 30 pounds. And they're both in gigantic chairs. They're very poorly positioned. Both of them require total assistance to be pushed. Okay. there's other issues that can develop from the being poorly positioned, right? And we know that these are exacerbated, especially in the geriatric population. Kyphosis, right? Because there's no support on that sling, seat, and back. They're going to start to become more kyphosed, get that posterior pelvic tilt. They're going to start having that forward head position. They might have decreased phonation because their head is down, decreased difficulty swallowing, all sorts of issues. We have to, try to do our best to advocate for these clients. You can see right here that this sweet little lady, she's got a whole blanket rolled up here next to her. This one, because it's black, it's a little bit harder to see, but you literally could fit two of her into this chair. It's so big. So again, we want to make sure that we're doing what is best and how can we qualify our clients for better chairs. So this is one of my colleagues' grandma, Erin's grandma, Helen. You can see that she's not positioned for either independence or function in either one of these chairs. So again, I also want to point out these are two different wheelchairs, two different facility provided wheelchairs, probably within days of each other in the same nursing home. So there's very limited support. There's very limited access to the rear wheels. The seat is hammocking. So again, very, very challenging for any type of positioning, okay? Non-removable armrests, gonna make it a little bit more challenging for lateral transfers, all of that. Excuse me one second. Okay, so let's look at research out there of what is best practice. So I did take a few of these and I am going to read them because I think it is good for us to actually read these. So participants with individually configured wheelchairs had greater improvement in safe and effective use of their wheelchairs than those with facility provided wheelchairs. I doubt anyone that's on this would disagree with that. Outcomes suggest that nursing home residents function safely at a higher level in their wheelchairs, individually configured using comprehensive wheelchair and seating assessment processes. Again, I don't think anybody would argue with that. And the adjustable axle is important to allow the user to be more maneuverable in smaller space because of that adjustable axle. So as we saw with Helen, poor positioning, now I'm going to introduce you to Oliver and his optimum positioning. Okay, so Oliver happens to be my other colleague's grandfather, my colleague Allie's grandfather, and that is Allie's baby, James. So Oliver happens to live in an area of the world that provides excellent funding with justification for clients who live in long-term or residential care facilities. Okay, so because of this, Oliver was evaluated and he was fit to this properly configured custom ultra lightweight manual wheelchair. So it was able for him to meet his mobility needs. This actually happens to be a carbon fiber wheelchair. He's an elderly person. Being allowed and able to move himself around optimally allowed him to be able to hold his great grandson without the parent worrying that he's going to drop it. I'd be worried if you put that same baby in Helen, he'd be bumping his head on the armrest that's out of place, worried that maybe the chair is going to tip over. I'm exaggerating just a little bit, but it is nice to know that there are places in the world that value mobility for the geriatric population. And so that just happens to be where Oliver was able to get his equipment. So let's talk about wheelchair appropriateness and what does this mean and why does it matter? Okay, so the degree to which the wheelchair meets the patient's functional and health needs and includes criteria such as wheelchair quality and durability. We think quality and durability is a big thing. Can it be customized? Again, can it be customized to what that client needs for their specific functional activities, whatever it is? And then inappropriate wheelchairs can cause adverse consequences to physical functioning, safety, quality of life, vocational and economic standing. So this is just a picture of a woman that I saw in a parking lot a few years ago. trying to get her out and into this chair, and her daughter, or this person that was the caregiver, trying to get this chair set up for her. And as I was watching them struggle, get this chair, get the client into the chair, get those leg twists into the optimum position, a few things went through my head. Number one, I'm pretty sure this person didn't actually see a seating therapist for this chair. Number two, this chair was probably dropped off because possibly they went and they talked to a physician and said she's having difficulty walking, and this is all that was given. It wasn't taken into a whole consideration. I actually did get out of my car and offer to help them get the leg rests on because I was watching them struggle so long with it. So other than the obvious reasons, what does it matter? Why does it matter why we talk about a wheelchair? Well, because lower level wheelchairs, those entry level chairs, those basic chairs, those hospital type chairs, if you want to call them, there's no ability for customization, and they're always of a much slower quality or durability. They're going to need to be replaced on a more regular basis, which does lead to higher costs and more money over time, and more time without the equipment because it's needing to be repaired and replaced. I know that's something that's a big thing that we're pushing, is trying to ensure that our clients are not without their equipment when they need it. So let's talk about discontinuance and weight. Okay, so abandonment is a big thing, right? 31% of users who've had a stroke and 38 to 50% of those with other disabilities will abandon their equipment prior to the intended use of time, the intended length of time, maybe because it doesn't fit properly. When you look at those two little ladies in the first slide I showed you, those don't fit properly at all. You could fit two of them in each one of those chairs, or you could at least fit the grandma, her cat, 3 purses, and four boxes of tissues. Again, there's so much space in there, it's completely inefficient. If they went to actually try to push that chair, their arms would be so far out here that, you know, they'd look like they're flying away. Okay, so there's a lot of studies that look at weight and how heavy is that chair for our main reason that wheelchair non-use for older adults. It's too heavy. They can't push themselves. So again, they're stuck with that lightweight chair. A physician may be writing for a lightweight chair thinking that they're going to get something that is custom and maybe ultra lightweight, but it's not. And so they're getting stuck with something that doesn't work for them. So let's talk about the normal aging process, right? And how can we get the justification from the normal aging process? So we're going to look both at muscle, bone, and skin. So we're going to look kind of at musculoskeletal and postural changes. So strength changes are first what we're looking at. And so we look at the definition of strength is basically the state or quality of being strong, okay? Capacity for exertion or endurance. And then what happens with age is sarcopenia, and that's the decline of skeletal muscle with age, okay? And so this chart here just looks at 60 to 70-year-olds, and this is where my parents are. My parents are in their 70s. Their prevalence of sarcopenia, 5 to 13%. As soon as they get over 80, it goes up drastically. And so these are just normal aging for someone. So there's commonly associated health issues with sarcopenia, frailty, disability, morbidity, mortality. These are normal strength changes. So there's a significant decline in muscle capacity. However, most of our geriatric clients are receiving these heavy standard wheelchairs like we discussed earlier. So it's just something to keep in mind as we continue to move throughout this discussion this afternoon. So strength, okay? So you can see out there that shoulder muscle volume declines significantly in the older adult versus the younger. And age-related changes in shoulder muscle volume can be detrimental to continued independence. This is so important. So this is Arthur, age 98. He was kind enough to show us some of these aging muscle, skin, things like this. You can see that he's got some wasting going on in here, some decreased muscle up in here. And remember that manual wheelchair users rely on shoulder muscles for propulsion. So we've got sarcopenia, we've decreased our strength, and we've also got decrease in muscle volume. So let's keep that in mind as we continue talking about strength. Here's another one. Decreased skeletal muscle related to age was a primary cause of loss of independence and falls. Shoulder pain and dysfunction also increases when starting the use of a manual wheelchair after skeletal maturity. So obviously Arthur, who's 98 years old, has definitely reached skeletal maturity. He's definitely on the decline when it comes to that. When we think about shoulder pain, we have to think of underlying pathology that could exacerbate shoulder overuse. So this, combined with the aging process, really does mean that optimum setup for prevention through prescription is necessary. So based on the evaluation of Arthur, he has widespread muscle wasting throughout his upper extremities, which is giving us the start of our justification for a custom ultralight chair for him. Let's look at range of motion. Okay, so decreased active and passive range of motion, combining with some of the other comorbidities of muscle contractures, arthritis in the joints. So this combination of muscular and bony changes that we've just said in range of motion could definitely lead to difficulty propelling that standard manual wheelchair due to the inability to customize any of the components. When you think of Helen in that chair that we showed you, the wheel is way back. There's no way to get that forward. So it's not going to be easy for her to move using her upper extremities. Range of motion in the spine. Okay, so we know that as people age, you lose some of the fluid that's in your intervertebral discs, right? So there's decreased in flexibility, which comes with that. There can be osteoporosis, depending on the severity, which can cause lots of issues and possibly even fractures. So this decreased mobility in the spine is going to start leading to those postural changes. It's a continuum. We've got strength, range of motion. Now we're going to go into the postural changes that can be seen because of these strength and range of motion changes. So we've got osteoporosis, which we just said. It's also very often associated with sarcopenia, right? So we've got osteoporosis, we've got changing and brittle bones and decreased bone height and all of these types of things. We also have decrease in muscle mass. So it's going to start being an issue for them to be moving around. We've got kyphosis, right? Because of some of the changes, the narrowing of the intervertebral discs, we start to get that kyphosis, and then the forward head comes into it. And we know what starts happening once that starts to go. So again, looking at these postural changes. So the spinal changes with aging often combine that thoracic kyphosis with the forward head position. And the forward head position in wheelchair users can increase chances of aspiration if we're not able to get that, which could lead to further medical issues, including pneumonia and possibly untimely death. So the elderly disabled population with this combination have much lower physical functioning and less independence with mobility. So we've got all of the combination of strength, range of motion, postural changes. They've given us the justification for a custom wheelchair. Well, what type of custom wheelchair? What can we do about it? All right, well, let's see. So we've got a few recommendations to counteract the postural changes. So you can start by changing the incline of the back, right? If we're trying to look at the non-reducible thoracic kyphosis and what can be done, well, maybe if we can open the back angle just a little bit, we can accommodate that. They can be back a little bit more and not looking like they're about to fall out and break their noses. You could either add a solid back, or you with hardware, you can get a little bit more motion changes with that as well. A proper cushion, a seat base. But remember that a lot of these are not options on the lower level manual wheelchairs that are often prescribed to our geriatric clients. And this is why we're bringing light to this discussion. It's so important to ensure that our geriatric clients are getting what is best for them. Skin. Okay, so just a disclaimer, it is well beyond the scope of this 1-hour course to thoroughly discuss aging skin, but it is well documented how age affects skin. So there's decreased subcutaneous fat and blood flow to the skin. Other risk factors, dehydration, decreased nutrition, incontinence, right? This is a big thing. And so it is important with any wheelchair seating and mobility evaluation that you do look at skin, a thorough evaluation of skin in the process of wheelchair prescription. It's very important to keep skin and tissue protection and proper selection of cushion and properties. We do know that, especially in the United States, cushions are diagnosis driven, and this is can be a part of an issue. But understanding that and trying to figure out how that works is really important to ensure that we're protecting the client's skin as well. So, quick disclaimer: Arthur is my grandfather. So I love that we have all three of our grandparents in this presentation, and I think it goes to show we've got 3 out of 3 of our grandparents. 2 of them actually need a wheelchair, and who knows, maybe someday Arthur will need it. He is currently an incredibly healthy nonagenarian, though he does actually have COVID at the moment, and he doesn't need a wheelchair right now, but he still demonstrates many of these age-related changes. And so when I was building this presentation, I said, Grandpa, can you please be an example for me for this presentation? Of course, he said yes, because I'm one of his favorites. But the purpose of this was to show how a relatively physically healthy elderly individual still demonstrates these changes, and how much more will they affect mobility for someone who has underlying health concerns, other diagnoses, all of these things. So thank you, Arthur and Oliver and Helen, for sharing with us. Okay, I think my client needs a wheelchair. Now what? Of course, Chrissy's going to tell us everything that we need to do. No, but we're going to put some framework on it. And I think that that's important because, again, there's never 2 clients that are exactly the same. And so we have to just kind of take some of these frameworks and the processes and put them into place so that we can give what is best for our clients. So I'm starting with the RESNA Wheelchair Service Provision Guide. I think, again, this is an incredible document out there. I know that it's being revamped, which I think is fantastic. But we can use this RESNA Service Provision Guide as a framework to ensure that we follow the steps to provide our geriatric client a wheelchair. I like how in this purpose statement, it says that it is designed for use by all participants, okay, in the provision process. And so it's really good resource how to ideally go through and provide a wheelchair. And I really look forward to seeing the updated version of this and where it goes as well. And so again, these are available on RESNA's website. You can pull it down for free. So again, I think it's really important when we talk about referral to a qualified professional. So I really appreciate how this says, if they're going to need a wheelchair and or a seating system on a long-term basis. Well, again, it's nice that they put in here long-term, more than 6 months, or permanent basis, that they should be referred to a therapist and a supplier who collaborate towards the common goal. And I really think this is so important. And when I first read this paper, probably about 3.5 years ago, I was really taken aback. I'm like, this is what I've been talking about forever. And here's a document that says what it is. So we should read these RESNA position papers, because there actually is a lot of good information in them. So again, they're there on the RESNA website and you can pull them down for free. So does my client qualify for a custom wheelchair? We have to rule out lesser cost options. So this is applicable in the United States or anywhere for someone who's probably within their own home or in a long-term care facility that does provide funding for an ultralight wheelchair, which in some areas of the world you have it, and there are a few states in the United States that have it as well. But you still have to go through this kind of ruling out process. So first, we've got to rule out an ambulatory assist device, a cane, a walker, crutches. Then we have to rule out the lesser non-custom wheelchairs. They have fixed height, fixed width, fixed back position, fixed wheel position. These are the ones that are not. Understand that ultra lightweight manual wheelchairs is not diagnosis dependent. I've done a lot of looking at different funding programs throughout the United States and Canada, and a lot of them, there are funding diagnosis limitations, not for ultra lightweight manual wheelchairs. So you've got the musculoskeletal and postural changes that occur with age are very well documented, as we showed with Arthur, and they can give you the justification for that custom ultra lightweight manual wheelchair. And so again, this is taken from another RESNA position paper that is being rewritten, and it's the application of ultra lightweight, but it says the most appropriate manual wheelchair for individuals with disabilities who will utilize the wheelchair for an extended period of time is properly configured. That means there's not room for 3 cats. Fully customizable. That means we can move it to fit where we need that client to be, of the lightest weight possible. So it's gonna be lighter than those chairs that are being put in there for our clients in the nursing facilities. All right, so now we're going to talk about setup. Okay, so we're going to look at these 4 things in setup and justification and how we can really make it specific to our geriatric clients. So we've got axle configuration, we've got wheel camber. If you would like more information on wheel camber, you can check out the one we just did when it comes on demand. We did an entire hour session on wheel camber, seat and back angles, and then seat to floor heights. Let's look at those and see how we can use those to justify for our clients. So axle configuration, this is the position of the rear wheel. And again, we've kind of taken the stance here that we fit the chair and the chair is properly configured, width, depth, all of those types of things. Okay, so center of gravity, where are we going to put that rear wheel? You can move it where you want it. If you want it for stability and safety, it's going to be more to the rear, or efficient propulsion. Again, we're trying to get it more forward to allow that client better access to that. So we know from reading lots of things out there that the vertical and horizontal wheel position is one of the most important adjustments that you can have to minimize impact on the upper extremities. Okay, so if that axle is more forward, it's going to make it easier for the client to propel. So this is a justification for any age. Okay, so why not our geriatric client? Why do we habitually just put them in that lower level chair and just say, they're not going to be that active anyways, we're just going to put them in that chair? No. Let's think about that. And what do they need to do on their most active day? And how can we set up our equipment to allow them to do what it is that they want to do? So here are some just photos again of what is the ideal, right? The horizontal center of gravity position and the vertical. But these are for somebody that probably doesn't have the age-related changes that we're discussing. They probably don't have a thoracic kyphosis and a forward head posture and decreased shoulder range of motion. So there's a little bit more room to play with. Let's work and let's get these axles moved forward for these geriatric clients. If we're worried about tipping, then we've got anti-tippers. There are safety things in place that we can put in there. So again, imagine for our client who doesn't have these age-related changes, it's important to have a proper center of gravity. So it's so much more important when we have those age-related changes. So it is very easy to justify when you think about using the upper extremities per propulsion, assuming that we have proper configuration of the chair. So here's Helen. She's going to show us again how poorly she's sitting in this chair, right? So we've used the above justification basically for anyone to have a proper axle configuration. Geriatrics are even in much more need. So you can see that she has a little bit of kyphosis and her shoulder is significantly in front of that chair. So here's where we can discuss propulsion for a couple moments here. So why do we always see geriatrics arching? And I have a few videos in the case example that I'm going to show you, and you'll see that they're only arcing, right? Well, why do they only arc? Couple reasons. They have very limited access to the rear wheels. So if Helen was to drop her arm down here, she'd probably only be able to get about this much of the hand rim. So it's going to be an arc. right? Limited access to the rear wheels makes it very difficult to have a proper and efficient propulsion stroke, okay? Therefore, choosing a chair that has a rear axle that you can move forward will assist your client in more efficient propulsion. Very important there. Okay, justification for wheel camber. Okay, again, anything that can be done to improve the upper extremity position for the wheels for a geriatric client is going to make propelling the chair easier. Okay, we know that wheel camber improves maneuverability and lateral stability. Okay, redirects the force, and it uses a more natural body motion when pushing a cambered wheel. It also brings the top of the wheels a little bit closer to the body so that we don't have to bring our shoulders out into such a position. And it also protects the client's hands, right? So think about geriatric skin, and what were we saying about geriatric skin, right? It takes longer to heal. There's decreased like fatty deposits underneath it. I don't know about you, but there's not a lot of fatty deposits in the hand to begin with. And so as hands age, the skin becomes thinner and thinner. It becomes so much easier. All they have to do is, hit a table with their hand, and their whole hand turns into a purple mess. So again, let's think about hand protection and how important that is. So just a little bit of camber is going to allow those clients to have better positioning with their hands. And again, it's a justification for that higher level chair that is not available on those lower level lightweight chairs. Back angle, okay? Open versus a closed angle, right? So an open angle, which is the picture here on the left, you can compensate for a weakened trunk, or maybe there's a tone, or you can accommodate a kyphosis. I think of a client that I saw very early on in my ATP career, and I didn't know then what I know now, and I tried to put a backrest, to kind of get around her kyphosis. It's not going to work, right? It doesn't do anything. I should have played more with the center of gravity, but I didn't. I remember sitting in her little apartment cheering her on that she could go from the threshold from the kitchen to the living room. And had we just, myself, again, hindsight is 2020, moved that center of gravity probably a quarter to a half of an inch, which was able to be done on the chair because we did get her an ultra lightweight chair, it would have been that much easier for her to be able to do that. So again, looking at those things, ensure that if you are opening an angle to accommodate a kyphosis and you look at the center of gravity, make sure you're using anti-tippers. We don't want our clients to be flipping out of the chair. I've been told that between these two photos, which has a change in back angle and cushion, that very shortly after this gentleman flipped himself right out onto the floor. So we don't want our geriatric clients flipping out onto the floor, because I don't think that that's going to be very healthy for them. Justification for seat height or seat angle. I think this is really, really important. And this is, again, a justification for that ultra lightweight chair that you're not going to get on some of the other. So the frame allows for it to be different from the front to the rear. So again, you can have that seat slope, or you could have it set at specific heights that are not available on lower level chairs. All you need to do is look at documentation for, are they going to be a foot propeller? I know we've talked a lot about upper extremities, but do we need that chair to be exactly where it is for doing a transfer? Why do we need that specific seat height, and how it isn't available on the lower level chair? So for example, the lower level chairs, there's no height adjustability. You've got your standard, which is your lightweight chair. Standard height is 19. Okay. You can usually get from 18 to 20. That's all you've got, 18 to 20. That's without a cushion. Okay. Standard of a low seat, or the Hemi chair, which is the K0002, is 17 to 18 inches without a cushion. So again, knowing these numbers is going to help you rule out those lower level chairs, because this will allow you to set it exactly where you need it to be for your client. So I've given you 4 justifications. Now we're going to go and talk a little bit about a case example that I worked with. So this is Scott. And what we're going to do is we're going to go through the wheelchair service provision guide process of how we got him with his chair. So again, if you're not familiar with this, I do believe there's a session on it at ISS, which I plan to be looking up. And if not, go to the website, pull down the old one and have it. It is a really good resource on how to ideally go through and provide a wheelchair. It includes these many steps, how to break it down into a manageable and attainable process. So we're going to do referral and assessment, equipment recommendation and selection, funding and procurement, product preparation, fitting, training and delivery, follow-up maintenance and repair, and outcome measures. So we'll start with referral and assessment. So I'm going to just start kind of the referral, and the referral for Scott came to me in a quite unorthodox manner. He is a friend of a family member of mine. So the family member is a massage therapist, called me up and said, hey, can you please help my friend? They're going to go to, I'm just going to use the term ABC DME to buy a new wheelchair today. Can you please call them? And I'm thinking, they're going to just go buy a wheelchair today? Like, so I'm trying to text my cousin and I'm trying to ask him some questions. Well, does he use the chair all the time? Is he able to stand, whatever? He's like, no, can you just call them? So I got Scott's wife's number, Mary, and I called them and I talked to both Scott and Mary. I asked a few questions and pretty soon set them up for both a seating evaluation for a power chair and an assessment for a cash pay backup manual or custom manual chair, as many insurances don't cover that custom manual backup. But as we go through this process, I think you can see how we came to the decisions that we made, both for the power chair and for the custom manual chair. So here's Scott, and he is in his mid-60s. He's 6'3", he's very tall, 250 pounds. He has Parkinson's. So he was a super active guy prior to knee surgeries about 2 years ago. You can see that he has a pretty significant kyphosis in that forward head posture. He has a head tilt to the right, which you'll see, and you can see it in some of the things, a lot of trunk weakness. He requires min to moderate assistance for a stand pivot transfer, and he has now lost his ability to ambulate, and he's using the wheelchair full time. Okay, so this is where I came into the picture. So equipment recommendation and selection. Okay, so the recommendation was that he be seen at a wheelchair seating clinic for a power chair. Okay, we're going to talk a little bit about that in a minute. But after completing the assessment, the history, the range of motion, strength, transfers, and looking at Scott propelling in the existing chair and then in the demo chair, this is how we kind of went through a lightweight versus ultra lightweight manual chair. So the scenario one was lightweight manual wheelchair. Okay. So Scott was dispensed a heavy duty lightweight wheelchair because of his size. At the time, he was a part-time ambulator with walker, and he used the wheelchair for long distances. He had a pretty progressive decline, which isn't surprising considering his primary diagnosis of Parkinson's and the combined knee surgeries. The chair was about 50 pounds with the wheel, so very difficult for Scott to move, very difficult for his wife to pick up and put in and out of the car. And I know you're saying, Christine, nobody pays for caregiver. I get it. I understand that, but it doesn't mean that we can't have the conversation and allow our clients to have a decision and make the decision as what's best for them. This had a sling back, a sling seat with a cushion, but very, very minimal postural support. So the justification, again, quite often, I think you've seen this scenario, not all the parties involved understand the big picture, okay? The client and the caregiver might say to one specialist, right, that Scott needs a wheelchair because he can't walk long distances. That specialist probably doesn't take into account all of the diagnoses, all of the prognoses, and they supply the off-the-shelf, the lightweight as it's the easiest. So let's talk about the justification and the thought process for the lightweight manual chair. Again, I want to reiterate, geriatric clients are quite often seen and treated by a lot of specialist physicians. And one physician, unfortunately, does not talk to the other. If the client or caregiver arises the complaint of difficulty with walking, that standard wheelchair is often the first to be prescribed, and the long-term implications are not discussed, along with client diagnoses and prognoses, funding, any of those types of things. There's a very frustrating part of this process is that there is not an easy process to follow, right? So the client and the caregiver and often the physician don't even understand the process and how it's supposed to work. When I first spoke to this gentleman and his wife on the phone, and I explained a seating clinic, they had no idea what that meant and what that implications for that were. And they see a specialist, a movement specialist for the Parkinson's. So now we did demoed an ultra lightweight manual wheelchair. So in the first, if you can mute yourself, someone's off mute. If you can look at the first one is him propelling in his current chair. You can see that beautiful arc. We're talking about arc and very limited access to the wheels. He doesn't have very good access to the rear wheels. Now this, you're thinking, that does not look like it fits him at all. It is a demo chair, okay? So still arcing, but moving with a little bit better pace. It's the wheels are a little bit further forward so he can actually access just a teeny bit more. So we want to ensure that we take the time to teach them, right? Often with the geriatric client, we get so excited to see them moving again, moving better than what they were before, that we forget to teach proper propulsion. So again, this is a word to myself, make sure we're teaching propulsion every time we're interacting with those clients. Okay, so again, now we're in the ultra lightweight manual wheelchair. So they requested a light and durable folding wheelchair as a backup to the power. And so the Helios C2 heavy duty was selected with the components and a background seating for postural support. So when we did the delivery, this is the day of delivery, the client was so excited and he wanted to actually test how light the chair was himself. So carbon fiber and titanium are great options for geriatrics for this reason. Again, I understand funding limitations. I get it. But letting them know what the options are, people are willing to invest in their health and their lifestyle if they have the means to do that. And so let's let them. Letting them know that carbon fiber and titanium are superior metals and they're lighter weight and more durable is doing what is best practice for our clients. So the justification. If we were going through funding, we're going to have the adjustable rear axle to be able to move forward so that Scott is able to access it because he has decreased shoulder range of motion and the thoracic kyphosis, excuse me. We did not put camber in the chair as it is 20 inches wide, so doorways could be an issue. We did open the back angle. Combined it with a backrest hardware to help accommodate and support his thoracic kyphosis. And we did give him a little bit of seat slope again to allow his trunk to rest back into the chair. So we use the components that differentiate the ultra lightweight from the lower category wheelchairs to allow for the changes that happen in strength, range of motion, and posture. Sorry. All right, funding and procurement. So in this instance, the funding was cash and the product preparation was between the manufacturer and the dealer. So the dealer and the manufacturer worked together in this instance to do the evaluation and they were going to do cash. So fitting, training, and delivery of the ultra lightweight manual wheelchair. So we fit the chair. We wanted to ensure proper fit and position. So we had a better position in this chair than we did previously. If you're looking at, you're thinking, Christy, he doesn't look all that great. Well, I'll tell you right now that that was not his final cushion. And so we left the axle in the vertical position where it was because we knew that the cushion that he was going to be getting would actually be a little bit taller and would put him up probably about an inch. We did open the back angle with support below his kyphosis to allow him to still use his upper extremities for propulsion. The training included how to remove the backrest, how to fold the chair, how to work all the components. I often have caregivers video the training in order for them to remember. They video it and then they do it themselves. And this ensures that they can both demonstrate proper care, either the client, the caregiver, or both of them. So I think that is a good practice. So follow-up maintenance and repair on the ultra lightweight manual wheelchair. So before they even left the dealer, Scott's wife discussed with the provider, the dealer, the ATP, what does preventative maintenance look like? Because they want to protect their investment. As they're getting ready to be delivered their power chair, they're going to do the exact same thing. They see that this is an investment in Scott's mobility and independence, and it's very, very important. So literally the day after this, Scott and Mary traveled to their winter home in Florida, and they had a follow-up with the Florida rep to deliver the proper cushion and the backrest because those didn't come at this time. We had a very small window in which to deliver this chair while they were in Michigan before they went to Florida. So outcome measurements. I did not complete a formal assessment. I do believe in them. And I think that the whom would be an excellent choice in this case. If you're unfamiliar with the whom, it's the it's a free one online. You can Google it. You can pull it down. It is a user and caregiver questionnaire. Okay, so it's looking at what do they think of their mobility, what do they think of their skin, what do they think of their positioning. It's an excellent resource. If you're not familiar with it, feel free to email me after, come by the booth, we can talk a little bit about it. But I took the smiles from a couple who hates selfies as a good outcome. Also, in follow-up with them 6 weeks after initial delivery, all they could say was how much they loved the wheelchair, how much easier it was for him to get around, and how much it was easier for Mary to help him and to use the chair where they're going. Again, they are looking forward to delivery of their power wheelchair. And they will be using both of them. But this is Scott. Just a week ago, Mary called me, his wife. I said, hey, I'm going to be doing that presentation. Would you send me some more pictures? So you can see he's got a little bit better support with the taller back and the thicker cushion. I believe that we could do some tweaking, maybe with the armrest to get him a little bit less leaning. You might need a little bit more contouring, possibly a lateral support. Again, it's kind of hard sometimes to do this between 3 parties over Zoom, but we're all doing the best we can with telehealth. He will be receiving his new power wheelchair shortly. So, my plan for him is to keep an eye on that lean to see if he needs an external lateral support at some time. So let's just kind of review best practices, thorough evaluation of our geriatric client using those physiological, musculoskeletal, postural things that we find in our evaluation to determine what is going to be best functionally and environmentally. Using that RESNA wheelchair service provision guide, I do believe provides a nice framework to go through that process to ensure that you're not missing important steps of the process, like I did with the outcome measure. Let me just remind you or say one more thing about the wheelchair outcome measure, the whom. It's to be done pre and post. And so because I didn't do it pre, I didn't have a good post. So I should have done that in hindsight again. So the recommendations, again, we talked a lot about the physiological, musculoskeletal, and postural age-related changes, and you can use those to match up with your justification of your wheelchair base and your components. It's there, we just have to pull it out. Educate our clients and caregivers why we're recommending what we're recommending, and understand that if they choose something that maybe isn't funded, that they are allowed to do a cash pay if they have the means to do so. I always say recommend what's best and then work our way down. If we don't ask for it, if we don't advocate for it, if we don't recommend these higher level technologies and things that are available, like carbon fiber, like titanium, like power elevating seats, like power standing features, it's never going to come up to where they're going to be able to be funded. So we need to advocate for our clients, teach them to advocate for themselves. And I think, we'll all be better off for it. So I'm going to take some questions here, or I'm going to look for the questions in the chat for 1 second. But I do just want to give a shout out to all of the manufacturers that are here. Come visit the booths. Take some time to look in the booths. It is a little bit challenging. Find on there where it says chat now or live demonstration or whatever, and take the time to look and talk to them about the products that they have. We are booth 901, so feel free to come see us in our booth. You can go right to live chat. Again, thank you for coming. And Joe, if you want to give them the CEU while I look here at the questions.
Can do.
Thank you. All right. Here's a great question. And I very much say anyone feel free to jump in on that. But how can we better educate physicians of this need for a geriatric population? I've had physicians decline to sign off on custom wheelchair evaluations for geriatric clients due to some of the assumptions outlined earlier in this presentation, or the physician is not seeing the need despite a discussion. Any insight would be appreciated. Well, I think it's case by case, and you have to just keep, I guess, educating our clients on how to advocate for themselves would be what I would recommend in this case. Honestly, it would be self-advocating is what I would recommend. Here's one other thing. Hi, did you mention earlier that position seating cushions can't be placed on a K1 through K4? No, that's not what I said. You can put positioning things on a K1 through a K4, but you cannot make the frame changes that you can make that can accommodate even higher on these higher level, the K5 or the ultra lightweight manual chair. So I hope that clears up that you can put aftermarket backrests on some of those lower level chairs and cushions, but you cannot get all of the changes throughout the frame. So thank you guys so much for coming and listening this afternoon and participating. I see that Joseph has put that in the chat.
Yes, and the CEU code for those of you that don't have the chat is YMFJAJ.
Perfect. And please, guys, take the time and go see some of your manufacturers. They'll only through tomorrow and this afternoon. I think there's, after the presentations are done, I think the exhibit is open until 7 p.m. So thanks everyone for coming. Enjoy the rest of the seating symposium. I'm happy that at least we're able to meet virtually.
Absolutely. Thanks, guys.